because it has results as a resident, but it's a at least $6,000, you know, and then it's encouraging patients to actually go through and pay for the services, because it's not like it's free. So, does anyone have any questions on your laser research? Okay. We're going to go over lasers a little bit more today as well, so we'll touch base on them as well today. Okay. All right. Guys, we're almost done with chapter 29 of faculty. Part 4, okay, longest chapter ever. So today what we're going to be talking about are dental implants, and I'm going to be spending very brief amount of time on the whole chapter dedicated to last semester. I'm just going to give you a very quick refresher on that to make sure you know the information and are comfortable with it. I'm going to talk briefly on periodontal microsurgery, which is a fancy word for just using a microscope when surgeons are engaged in surgical procedures. We'll talk about laser therapy a little bit more. Now, with laser therapy, when we talk about it today, I'm not going to go into substantial detail on lasers. The reason being is because I can spend easily 8 hours of lecture time just talking about lasers. When you get certified, you usually have to spend a whole day learning the material. So we're barely going to scratch the surface today, okay? Who here showed up? I think I might have already asked. Who wants to get laser certified? Okay, perfect. So when you get certified for lasers, you'll learn all the nitty-gritty. Okay. We're going to talk about different biological advancements that we can perform when engaging in surgical procedures. We'll talk about suturing and periodontal dressing. And then finally our post-op. So I'll give you all of the information that you should be talking to your patients about. And we'll talk about the actual post-op procedure and what hygiene is kind of involved in them. Okay. All right, so dental implants. So who remembers what is the most common type of dental implant used today? Not osseous, and osseous. Okay. Osseointegration is what blocks and osseous implants are the ones that are most common used. Right, so make sure you know that. All right, so here's the different types of implants. Like I said, I'm quickly going to go through this. We talked about this in detail last semester. So basically, we have the option to either do an immediate implant placement or a delayed implant placement. Those are kind of the first two pathways. Immediate meaning we're going to pull out a tooth, we're going to pack ungrafted material in the pocket, and then we're going to place the implants all in one day. Okay. We have the delayed implant placement, which basically extracts the tooth, places the bone graft in place, and sutures it up and lets it heal. Lets the bone graft kind of heal, and 3 months later, 6 months later, then we flap the patient back and then place the implant. So immediate or delayed. Okay. We also have 1-stage versus 2-stage approaches. 1 stage is basically we place the implant and the abutment's going to be sticking out. And basically it's going to be ready for restorative. We're not going to need to go back in and do another procedure or anything like that. Whereas with the 2-stage approach, we go in and the pictures kind of show this too. But that's the one where we go in, we place the implant, we suture the tissue up so we can't see any part of the implant body. Let it osseointegrate, and 3 to 6 months down the line, we get a second appointment for another surgical procedure where we cut into the tissue to expose the underlying implant. Okay. Now, between all of these, it really just depends on the surgeon and the patient. So are there site-specific factors at play? Is there enough bone present? If not, do we need to place the bone graft in material to allow us to come back and place the bone or place the implant at a later time? Are there patient-specific factors? For example, with an immediate implant placement, if we're extracting tooth number 8, do you think the patient's just going to want to have a tooth right in front? Okay, so the patient-specific factors that come into play as well. What are their expectations and what are their wants too? And then technical factors as well. It's the level of experience of the surgeon. What are they most comfortable doing? What do they feel like would be most ideal for this patient, especially if they're collaborating with other disciplines? So there's really not one specific technique that's gonna be more ideal than the others. It strictly depends on that specific one. Okay. Any questions on that so far? Have we remembered some of this from last semester? Yeah. Perfect. Okay. All right, so here we have that immediate implant placement. So you can see we have a tooth that I know a lot of you guys have seen this type of situation where the tooth is broken off right at the gum line. 9 times out of 10, that's not going to be restored, right? So they'll go in, extract that tooth out, and you can see that's where the socket is, and they place that implant in there. Sometimes with immediate implant placement, they may have bone around it. It just depends on the situation. Then we have our one-stage approach, and that's the one where the implant body is visible on the gingiva here. So here we have our flap, so we have the tissue flap back, here's our bone. They're going in and placing the implant. And here is, this looks like our abutment or a tightening screw here, and then our healing cap is placed on top. And notice how the tissue is sutured around it. So basically with the one-stage approach, when they're ready to restore this implant, they don't have to cut into the tissue again. All they have to do is take off this little healing pad, take a quick impression, and fabric is crown piece. Okay. Here's another example of what that one-stage approach looks like. So basically, everything is completely submerged. We have the implant body completely in place. And now we have these healing caps that are sticking out and allowing for the gingiva to kind of heal in place around it. And when they're ready for restoration, 3 to 6 months from now, they'll take these off and place on purpose. And most of the time, since these guys here are anterior teeth, they'll also have a patient in like almost like a flip humor that has teeth, so they're not walking around with teeth. And then lastly, here's our two-stage approach. So you can see we have the implant placed here, and this was a good example of where they're placing bone grafting material on the same visit. Everything's already flapped open. Let's just do what we can to make sure that implant osseointegrates. So that's what that is up there. And notice in the end of the equipment, how you can't see the implant anymore. So they basically sutured all of that tissue up over top of it to really allow the implant body to kind of osseointegrate and not have any external factors. Now, this one, like I said, is going to require a second appointment. So this patient's going to come back 3 to 6 months from now. They're going to make a little incision once this is all healed and basically cut the implant body so you can see the image of this. Okay. All right, so healing expected after implant placement, osseointegration. This is where that's coming in. Okay, osseointegration is key to implant success. If the implant is not osseointegrated, it is going to fail. Not if it is. Okay, critical for implant stability, critical for the long-term success of the implant as well. Okay. Now, here's this little picture this was pulled from chapter 9 for last semester. So try and remember what our tissue looks like as well. Remember, we don't have any cementum. Okay, so because we don't have cementum, we're not going to have our supragingival fibers embedding into the implant body like they do with a regular tooth. Okay, no cementum. So we really only have our fibers that are circling the tooth. They're our circular fibers. And then we have the fibers that extend from the alveolar bone into the connective tissue. But nothing fiber-wise is able to connect to that. That's why we have to be really cautious when we're probing, not to use too much force because there's less resistance. So it's easier for us to puncture through the JV. Okay. So no gingival fibers attaching to the implant body, but we do still have a sulcular injunction on the groove. So all of that is still present. It's just a little different with how much the fibers are present. Okay. All right, then periimplantitis. Okay, so always make sure you're taking X-rays of implants. We need to be assessing them for bone loss because we know that probe depths aren't. We aren't able to definitively determine a radius health of probe depths. Right? So we want to really make sure that we're assessing them radiographically for any signs of bone loss. And remember, when we're looking at the bone loss, What we're looking for is if there's loss starting around those threads. Okay, the top portion of the implant is very, very smooth. So we're very rarely going to have osseointegration towards the more peripheral part of the implant body. So when you guys are looking for periimplantitis, I want you to draw your eyes to where the threads start. And that's where you can see some attachment loss starting to form, especially on this guy here on the mesial aspect. You can see those threads are starting to be exposed. And then when they actually flap this tissue back, this just goes to show how x-rays are two-dimensional, right? They flap this tissue back and actually look how much of those threads are not embedded in bone. We can't tell that off an x-ray because that's all the facial aspect. So it's very important to be very cognizant of implants and diagnosing periimplantitis as quickly as possible so we can try and basically address if there are concerns that we can try to solve. So in this instance, what they did was they saw, hey, this isn't looking so good. Something's starting to happen around these threads here. They flap it open and they're like, oh, look at all that exposed. So what they did was they went in and packed more bone, placed bone drafting material, and sutured it back up. And this post-op x-ray was taken 10 months after that surgical procedure. And you can see, especially on the mesial, the threads look way better now. We don't have this gray darkening area kind of happening up here, right? So that's what's so important to be assessing for periimplantitis. Because there are things we can do if we catch it early enough. If we don't catch it early enough, it's got to go. We're going to need to, right? There's a close-up there. It makes it a little easier to see. Hard to see with the ambulation, but. All right, what type of instruments are safe to use around implants?
Titanium.
What else?
Non-positive.
That weird area, right? So I want you guys to know when you're practicing, you can use titanium for sure and gold for sure. Plastic is one of those things that is very much on the gray area because for years and years and years and years, they thought plastic was safe. And recent studies, meaning like the last 5 years, we started seeing there's actually some microplastics that are hanging out in these sites, likely associated with implant failure, likely from instruments with plastic. So I personally am not going to ever scale an implant with plastic instruments anymore. Okay, and I've attended 2 different CE courses now that have also reiterated that. So when I'm giving you an exam, I'll be very specific in my verbiage to make sure to make that clear to you guys what I'm asking. Okay, but when you're practicing, I wouldn't even use plastic instruments anymore. Grab titanium or gold tip scalers. Okay. All right, can we do Cavatron on them? No. Okay, perfect, beautiful. So just a reminder to how to manage our implant here. So make sure that you're taking PAs yearly of the implants. Sometimes we can see the entire implant on the piping. It depends on the placement of the film, and it also depends on the type of implant, how long it is. But if you're not able to see the entire implant body, snap a PA. Okay, you need to be assessing for periimplantitis. Do not probe these teeth prior to osseointegration. You can probe them after everything is healed. But before that, do not touch these guys because you can definitely ruin whatever attachment is trying to do. Okay. The rule of thumb is usually 3 to 6 months minimum after the surgical placement. So I say rule of thumb, but I also want you to always refer back to the surgeon. Okay. Most surgeons are in this time frame. But there might be some surgeons out there that are like, you can touch the site for 8 months. There's no possibility, right? So always refer back to what the surgeon says, but definitely no more than 3 months, okay? When we are probing, use your plastic or metal probe, okay? We're gonna have you use plastic while you're in our clinic, but technically the research is showing that you can't use metal as long as a very light pressure is being used. Because you're not going in and you're not going to scratch the implant while you're with probe unless you're doing something really funky, right? But if you're just going in and using light pressure, it's going to be totally fine to use a metal probe. The reason we have you guys use the plastic probes while you're in our programs because you're still students, you're still learning and adapting and everything. But once you're in the real world, we're okay with the metal. Because again, that plastic is getting into that weird gray area. Could a plastic probe leave some residue of plastics on the implant that could lead to failure? That's what the studies are trying to investigate. Okay. Now, remember, when you do probe implants, we can't definitively define a range of healthy probe depths. So healthy teeth, we know 1 to 3 millimeters is perfect. We can't say the same for implants. The tissue is completely different, and the studies have not been able to definitively state, yes, a 3 millimeter pocket is healthy for an implant, okay? So what we do when we probe is you're always going to assess for changes in the probe depths. Okay, this was a 4 millimeter last time. Today it's a 6. That's a pretty big difference. I might want to be concerned about that. It was a 4 last time, and a 4 today, or a 5 today, might not be grounds for raising the red flag. Okay? Does that make sense? Like we said earlier, always use your titanium instruments when they're available. There are some offices out there that don't have titanium instruments, but they are a little bit more expensive. So if you end up working for an office that does not have titanium, and you either have the option of stainless steel or plastic scalers, what are you going to use? Exactly. Okay. Absolutely no Cavitron. Okay. Even there's some Cavitrons where they advertise them as like shielded or covered, where they have like a plastic covering over the tip. No to those either. So again, that ties into the plastic getting embedded around the tip. Okay. Now, with implants, we're going to have patients on 3-month free care for the first year. Okay, so after they're done with their implants, everything is stabilized, it's been restored, they have a crown on the tooth now. We're going to tell them we're going to see them every 3 months. Why do we want to see them every 3 months? They're cleaning. That is the biggest one. Are they cleaning? Okay.
Oh, no, it was,
Perfect, yep. Are they effectively cleaning these implants? Because these are way different. You've ever had an implant, who here has implants? Yes. Okay. Well, they feel way different than regular teeth do. And it usually takes a different technique to floss approximately. And so it's really important to kind of keep a really close eye on patients in the beginning to make sure, are we cleaning this properly, or are we starting to develop these cycles? Are we starting to get worried that it's going to lead to periodontal? Right? So you really want to phone in home care and monitor it for the first year to make sure it's healthy. After that, if the patient's good with their home care and everything else looks stable, then they can go back to 6 months. Okay. Can we perform air polishing on implants? No.
It depends.
Here it is. It's on the counter. The license one we want exactly. You're spot on. Okay. Great job, Kristen. Yes, and lots of it with glycine powder. The glycine powder is the one that can be used self-complete, and it's the one that is used around implants as well. It's very, very safe. It's not an aggressive abrasive. Sodium bicarbonate, absolutely not ever. You will ruin that implant surface. Okay. So the reason I bring up air polishing as well is because there's a lot of studies, and both city courses I attended both stress that air polishing is really beneficial for implants. It's extremely beneficial for implants. They just clean them beautifully and make sure that the surface is perfectly clean. So a lot of clinicians are recommending, researchers are recommending air polishing. It's kind of standard of care. So don't be shocked if throughout your career that becomes a standard of care across the board. Okay. So any questions on implants? I know that was a lot that I just threw out here, but all right, perfect. So periodontal microsurgery here, this one's pretty straightforward. Basically just saying any surgical procedure can be done with a microsurgery. Okay. So here you can see a couple of examples. I actually really like this example down here. This shows a surgeon showing the difference between just using his naked eye, using glasses, 2.5 loops, which is usually where we're at, 4.8 loops, and an operating microscope. Look at the difference in his ergonomics. Right, so these microscopes help substantially with ergonomics, right? And a lot of them are equipped to have dual-sided microscopy, so sometimes the assistant can even down on and use the microscope as well. Okay, So using microscopes can be great because it's gonna help with increased precision, right? Just like when we're working with our loops, we can see things a lot easier. It's the same thing when you're using an operating microscope, right? Way better ergonomics, and they tend to get more rapid healing when we're using a microscope as well, just because the precision is more spot on. So usually the surgical wounds are a little less involved. They don't have to be as big, so you don't need to open things up as much to see because we're zoomed in. Okay. And then your book also mentions advanced patient acceptance as well. A lot of the times when patients see that there's a lot of tech utilized in dental offices, they feel a little bit more secure. So usually the surgeon will go in and say, yeah, I'm gonna use this great microscope and fix your teeth right up. Right? Patients will be more acceptable of that, or accepting of that, okay? That's all I got, that's all I got for microscope. Pretty straightforward. Okay. Any questions on that? All right. Laser therapy. Okay, let's get into this here. So like I mentioned earlier, scratching the surface, I'm really not even going into like nitty gritty details of how the laser is used, because that takes hours and hours, okay? But when you hear the term laser, basically what it stands for is light amplification by stimulated emissions of radiation. Okay? LASER, that's not right. That's where we get our lasers. Now, the laser is a form of radiation. Okay, and this is why we have to go through extensive training. This is not something you just pick up and roll with it, right? Because if we do not utilize proper technique with the laser, we can ruin people's tissues. Okay, it really cause some issues. So it's really important that we're adequately trained. Do not ever, if you end up not being certified, do not ever pick up a laser if you are not certified. There's some dental offices that will say, oh, well, I'm certified as a dentist, so you can go ahead and do it. Do not, okay? Do not touch the laser. Because if you hurt a patient and cause irreversible damage, you're gonna get sued. It's not a question. If that patient's coming after you, you're gonna like it's gonna, okay? Now, laser, I love laser because it has so many wide aspects that we can use it, okay? We can use it for bacterial reduction, which can be used on any type of tissue, where you basically just use the laser to kill bacteria. And then we can also get in more involved versions of the laser, where we have it at a higher setting. And you can basically go in and cause the tissue to kind of coagulate. We can basically remove granulation tissue with it as well. And then as it goes up higher in the setting, we can't, but the dentist can use it for gingivitis, like we saw. They can use it for soft tissue purifying if they find that necessary. They can even use lasers. It's a hard tissue laser, which is a different setting than what we use, but they can even use lasers to remove decay. So they don't need to anesthetize patients, and they go in and remove the decay. They have the ability to remove a lot of different types of tissue structures. Okay? Now, when we're using the laser, we're always going to be using it in an instance where we can't cause irreversible damage. Okay, so again, we're not going in and cutting away down tissue. What we're doing is targeting bacteria and basically killing the bacteria and removing the granulation tissue to clean the pocket out. Okay. Now, like I mentioned earlier, these can be set at a lot of different wavelengths and settings, which is why it's so important for you to know and be properly trained on this. Because if you don't know the proper wattage that you will be using, the laser is not really going to tell you. So you can end up damaging the tissue. Okay. So it's going to incise and coagulate the soft tissues. So again, this can be used for gingivectomies. These can even be used for biopsies. Some surgeons will use these instead of scalpels if they're biopsying some tissue. Okay. Now, the proposed benefits of laser, like I've already said, meet bactericidal. So they're basically targeting the periodontal pathogens and killing them. A lot of you guys mentioned that in your research as well, finding that it kills AA and kills Periodontalis, right? Which is fantastic. Those are two of our really bad periodontal pathogens. So I really love using laser on all varieties of patients, not just period patients, because maybe they have Periodontalis present, but maybe it's not enough to actually start triggering an inflammatory response. So let's kill it with this guy, right? It'd be really, really great. It can basically deliver that precise, intensive energy to the pocket without damaging adjacent tissues if you're using it properly. So basically, it's not gonna cause any damage to your patient if you're following proper directions. Now, there's a lot of studies that have been investigating the ability to form a fibrin clot, okay, fibrin clot in the blood. And what some studies have found is that that actually creates that clot that the laser forms, creates a physical barrier, kind of like our barrier membranes do, with fatty tissue regeneration. And what some studies have shown is that that clot is actually enough to stop the epithelial downgrowth. So it's gonna allow connective tissue, bone, and differentiated cells from the PDL to move into the area, which can then technically stimulate periodontal regeneration. When Dr. Wetman comes out 2-3 weeks, I'm willing to bet money he's gonna talk about periodontal regeneration and using lasers. He has a lot of good case studies that he's personally worked on where he's used a laser at a higher setting than hygiene can. But he uses it and actually touches the bone and it regenerates. So these lasers can be really, really beneficial. At the end of the day though, they're still inconclusive and no matter what, they still have to be used in conjunction with lesotho. Okay, or with some other form of therapy. We're never just gonna say, hey, we're gonna do some LDR and call it a day. No, we need to be doing this in conjunction with lesotho. And that's why the AAP basically says there's not enough evidence to say that the laser can be used as a single form of periodontal therapy. Okay? That makes sense? Besides this, another reason why I really like using lasers on my patients as well is for herpetic lesions. If patients have herpes, we know we can't treat them, right? But guess what? They're already in our chair. You're already miserable with kids, so why not let me laser it for you? Charge you $50-$60 and it's gonna help it heal way quicker than it would traditionally. Okay, so really, really beneficial there. Now, the main reason why laser therapy, another reason why laser therapy is controversial is because, like I said, the units are very expensive. It's about $6 grand minimum, okay? Then patients have to pay for the services, right? Anything we do, it's not gonna be free. We're not just tacking this onto an SRP. So if you work in an office that utilizes laser, you're gonna have to be willing and able to talk to your patient and educate them on why they need to have laser therapy done. Most of the time, it's anywhere from $35 a slot to $150 a slot, depending on the office. That to me is where I start getting frustrated. I'm like, is the evidence 1 millimeter of attachment gain enough to justify $400 for the whole mouth? That's another reason why I guess it's super fun, which is because they are having to sell it to the patient. Basically, there are benefits, but is it enough for the cost that we're charging the patient? That's where it gets benefit. Okay. All right. So that's my overview of lasers. If you guys want to learn more, take that certification course. And I highly recommend, especially if you're going to work in Arizona, there's a lot of offices in Arizona require laser certs. I would say for me personally, I have it's kind of tricky, but with the ability to utilizing laser, the dentist is gonna be on board. So for me personally, I would rely on the dentist as well, and say, okay, this is what I'm recommending. I'm gonna have the dentist come in, do their exam, we're gonna talk about the dentist, and then I'm going to say, okay, well, so need SRT, I also talk to them about laser therapy, and then usually the dentist is like, oh yeah, let me give you my sales speech. So that period from both of us working together, that was ended up. So really important how the dentist is collaborating. Any other questions on that? All right. So biological enhancements now. What we're talking about biological enhancements are different types of chemotherapeutic treatments that we can essentially put on the tube during surgical procedures. And it's going to be basically placed subgingivally underneath the gum, usually during a flap procedure. Okay. Now, the first type of biological enhancement that we should look at is root surface modification, which technically we kind of do a form of root surface modification when we're scaling teeth, right? So mechanical root preparation and chemical root preparation are kind of two main categories here, okay? Mechanical, like I said, that's what we do when we're scaling reparations, right? So roots have to be free from biofilm, calculus, any other contaminants in order to stimulate healing. We know that, right? And that's why scaling is basically incorporated into every periodontal procedure. The last 3 weeks, you've heard me basically say, yep, we flap this tissue back and then we're gonna scale it. We're gonna go through osteoresective surgery, we're gonna flap the tissue back, we're gonna scale it. Anytime we're performing surgery, 9 times out of 10, they're gonna be scaling on their roots, okay? So mechanical root preparation is extremely important. And then we also have the ability to kind of chemically change root surfaces. Okay, so chemical biomodification mediators. And these can be referred to as root conditioning agents. Root conditioning agents, okay? There's basically 2 broad examples of root conditioning agents that I want you guys to know about. And I also want to kind of backtrack a little bit. All of these things that we're going to talk about in this next section are probably going to develop throughout your career. There's current research happening with a lot of this stuff, okay? So don't be shocked if in 5 years, all of a sudden there's this new magical root conditioning agent that researchers have found, okay? And we're gonna talk about kind of where the studies are at right now. So EDTA, I cannot pronounce that word for the life of me, so don't ask me. Okay, but this is an acid, okay? It's hard, I'm like, that's worse than AA. Now, what this acid is basically doing is it's going on and it's flushing. And it's going to remove the sphere layer, right? It's going to remove the dental sphere layer. It's going to remove any exposed ends of collagen fibers. And it's also going to remove any endotoxins, right? We've kind of heard studies about endotoxins embedding into the cementum of the tooth. This acid is basically going in and treating that, okay? Now, this guy here has questionable positive effects on the outcomes of surgery. Meaning, it doesn't do anything really negative, but it also doesn't have a profound clinical data that shows, yes, we should be doing this on every single area, right? So kind of questionable, but it is used. There are clinicians out there that do use that. They've also looked at tetracycline, right? Now with tetracycline, when they're using that as a reconditioning agent, they're not going through using it to kill bacteria. They're going in with the intent of triggering the migration of fibroblasts. So tetracycline can actually trigger fibroblastic activity, which is great. That's going to help them build the collagen, right? So in some studies, they've actually coated the tooth with tetracycline and clinical studies, but they've coated the tooth with tetracycline to clean it up and allow it to heal. Now, same thing with this one here, questionable results. It didn't harm anything, didn't make anything worse, but it's not like we got, oh, at least 5 millimeters of attachment here because of that tetracycline. They can't definitively state that's going to be ideal for periodontal patients. Okay. So here's an example of the application of EDTA here. So here's the root. You can see that it's been prepared and flopped back and everything. And over here, there's this little gel-like substance. That's that acid that they're basically placing on the tooth and the surrounding tissue just to kind of try and clean everything up and remove anything that's going to impede the healing process. Okay. Here's an example of the application of tetracycline. Super, super exciting here, right? So this one, they didn't really flap the tissue back. So what they're doing is they're basically scaling on the tooth to clean it up and applying tetracycline onto the root surface to see if they can stimulate any fibroblastic activity where this recession is. Again, not super profound. Any questions on that? How are we doing? Doing great? You okay a little bit? A couple more slides. Okay, growth factors. So this is one of the ones that I'm willing to bet you money is going to change substantially throughout the career. Okay. So basically, we know that growth factors can be really beneficial systemically because they're going to go in and stimulate cellular growth, right? same concept kind of comes into place, but they're not. So basically, we have proteins that are circulating throughout our body that directly regulate cell growth and development. And so what researchers have basically attempted to do is targeting these growth factors, localizing them so that we place them around the sites that are experiencing periodontal disease to see if they can trigger regeneration. Okay. So currently there's a lot of different studies out there, but the two main ones they're looking at are platelet-derived growth factors and insulin-derived growth factors. Okay. And that's pretty much all I got for you on this one. There's not enough evidence to definitively state insulin-derived growth factor does X, Y, and Z. Platelet-derived does X, Y, and Z. So this one definitely needs more research for clinical use, and it is very, very promising. Okay. Now, enamel matrix derivatives. This one's a fun one. This one has quite a lot of studies showing efficacy here. So this one is FDA approved. It does get used. Okay. And basically what they do is they take proteins that are extracted from two buds of pigs. So then we're going back to pigs. Okay. We basically extract those proteins out and place them intraorally in the patient's mouth. Of course, after going through like sterilization practice and all that to make sure there's going to be transcription. But basically what they're finding is that these enamel matrix derivatives to basically stimulate regeneration. And they do that through angiogenesis and osteogenesis. Now, the studies haven't been able to definitively state what is happening with enamel PhD, and they're really struggling trying to figure out exactly what's happening. But what they found is that some studies will show that we have increased attachment. Great. We want to get more attachment in the PDLs that we've lost it. It can increase the differentiation of PDL stem cells. Okay, so those undifferentiated stem cells from the PDL basically move into other areas and turn into fibroblasts, fibroblasts, even and osteoblasts. And so they're finding that incorporating EMD into surgery can basically try and trigger those PDL cells that are undifferentiated to turn into osteoblasts or cementoblasts. Okay. This can also decrease the proliferation of epithelium. We've talked a lot about epithelium in the last couple of weeks, how it can kind of be naughty during the surgical process, the healing process, where it just needs to be quick. It moves quicker than the connective tissue. So if we're going in with the intent of regenerating the tissue, we have to stop the epithelium, because if the epithelium isn't stopped, the true regeneration doesn't ever happen. So they're finding that EMD can actually stop epithelium from growing down to give the other tissue a chance to regenerate. And then it can also stimulate the release of other important growth factors too. We just talked about the potential of growth factors, but they could have potential to perform regeneration. So these are kind of the things that the studies surrounding EMD have found, and that's why the FDA has approved it. Because there's enough out there to say, okay, this actually has some really promising results. And a lot of studies too have shown that it has really high efficacy when we use it in conjunction with bone grafting, or if we use it in conjunction with the GTR situation. Very, very important. Okay. Questions on that one? Is there a CE on this? Oh yeah, there's CEs on like all of these biological enhancements. Yep. Usually if you attend they usually have like weekend-long conferences through like the ADA or their Academy of Periodontology. And usually those big weekend events are the ones that have really interesting stuff like this. So definitely, we'll definitely recommend those. All right, so here's an example of kind of a combo therapy with that enamel matrix derivative. So you're off on the left-hand side. Here we have the EMD, okay? And then over here on the right, they've actually placed bone grafting material. So after they treated the area with the EMD, they've gone in, placed the bone graft, and then placed, you can't really see it because it's covered in blood, but there's an area membrane kind of as well, okay? And basically suture everything up. And this right here, this combo is what has shown very, 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 very good results with regenerative properties. So another really good alternative that some periodontists or surgeons might want to use before. Okay? Oh, no, just go. So like that, tack on the bone graft, tack on barrier membrane, tack on lab, the whole surgery would probably be like a grand. I'm like, that's for one, exactly. And so some clinicians might offer an enamel matrix derivative, they might even offer some of the next ones that we're gonna be talking about, but the patient might not take it on. They might say, no, I don't need that. And they can still proceed with the surgical procedure, that's totally fine. Usually we kind of will give these extra additives as an option for patients, okay? All right, platelet-rich plasma. So now we're gonna start talking about blood a little bit, okay? Yeah, we talked about this in okay. So platelet-rich plasma, basically what they're doing is they're gonna take our blood and mix it all up to basically localize the plasma that has a lot of platelets in it, okay? So PRP is gonna be obtained from an autogenous source. What does that word mean? Yourself, yeah. So if you are getting PRP therapy while you're in the chair and you're about to get your dental work done, they're gonna draw your blood right then and there, okay? Now, what they found with PRP, and this is actually, there's two different components. We'll talk about platelet-rich fiber next, but there's two different components of this type of procedure. This is the very first one they ever did. So this is called first generation, okay? And what they found when they used platelet-rich plasma is when they replaced that in the surgical site, it really helped to initiate wound healing, and it really helped to enhance periodontal regeneration. Plasma is an amazing thing. Our blood is an amazing thing. They're doing a lot of stuff completely across the board medically regarding blood. Okay? Even from an aesthetic standpoint, there's facials out there that utilize blood and kind of do something like this as well to stimulate collagen. So this is an area that is very well researched and is definitely used in multiple avenues of not only our field, but basically in every field that's filled with patient care. Okay. Now, the one thing with PRP is these guys here have to be mixed with an anticoagulant prior to entering it into the mixture, which I'll talk about on the next slide. Okay. Now, what they found is that the issue of mixing an anticoagulant solution in the blood prior to extracting the platelet-rich plasma out of it is that anticoagulation can actually prevent the full coagulation afterwards. So even after they mix the blood up and have extracted the platelet-rich plasma from it, there's still anticoagulant properties within the plasma. And we know how important wound healing is, especially in perio surgeries. And they found that anticoagulant that's residual in this plasma can still possibly interfere with wound healing. Okay, so it's kind of an iffy area in the studies. Okay, they also are unclear whether the growth factors that come from this are in a high enough concentration to even have much of an effect. Okay. So let's talk about the process of getting these guys. So this looks like, okay. So when they're obtaining PRP, it is a multi-step process. This is obviously an extra cost for the patient as well. Anytime we're adding in any new procedure, it's going to impact on it. It's usually not incorporated in. Okay. So what they're going to do is they're going to draw the patient's blood, acupuncture. Then, like I mentioned earlier, that blood sample is going to be mixed with an anticoagulant because they don't want the blood to start clotting while they're trying to mix it and separate the different components of the blood. That's why they add in that anticoagulant. Then what they do is they take the blood sample after it has the anticoagulant placed. They're going to place it into a little centrifuge here. What this thing does is it whips the blood around really fast. Okay. And during that process, that's when the components of the blood start separating. And over here in this picture, you can kind of see the difference. All the red blood cells will kind of focus down at the bottom. Then we'll have platelet-rich plasma in the middle and platelet-poor plasma up top. So once that's done, and they have their little vial that looks delineated like this, They stick a little syringe where the platelet-rich plasma is, extract that out, and place it on the surgical site. Okay. Now, before they actually place it on the surgical site, what they actually do is they'll also mix it with bovine thrombin, okay, so cow thrombin, and calcium. And that's going to help stimulate the platelets to release more growth factors. Again, as I mentioned earlier, we don't know how substantial and concentrated those growth factors are. Is it enough to really do that much of that? Okay. Then after those are mixed, then it's placed to the surgical site. So the downside of this type of procedure is lots of room for error, right? Because here we are taking the patient's blood, but before we even do anything, we're adding in anticoagulants. And then once it's done mixing, then we're going to be adding in bovine thrombin and calcium. Bovine thrombin is more expensive. It's not that easy to get as well. So then we're actually adding in these guys here as well, which again is more room for clinical error. So if we add in too much, but if we don't add enough, it's that can affect the healing. So the patient going to have a reaction to bovine thrombin. Okay? The patient going to be okay with using bovine. All these different functions that kind of come into play with PRP. Okay? But the studies have been promising enough that this is utilized regularly. And this actually kind of led the way for our next component of platelet-rich blood, which is called platelet-rich fibrin, and it's our second generation. Okay, so here that kind of paved the way for this guy here. Okay, platelet-rich fibrin. So just like our PRP, this is also going to be obtained from an autogenous source. They're taking the patient's blood right then and there. Okay. Now, the process for actually obtaining the platelet-rich fibrin is almost identical as that last slide. Okay, they're still going to go through and take the blood, place it in the little mixer, mix it up and get a separation, and then take that separation and place it into the surgical site. Okay, but there are a couple key changes. Now, the one nice thing about this platelet-rich fibrin is they realized with PRP that there's so much room for clinical error, right? So they were trying to figure out a way to not have to add in a bunch of different things to the blood. And that's how they came up with this method. So this does not require anticoagulants. Right? It does not require the use of bovine thrombin as well. When they're mixing this in the centrifuge, it has a different setting that it goes through, so they're not as worried of anticoagulants. They're not as worried of coagulation during the mixing process. Okay. But the really nice thing is that it doesn't allow for any adverse effects because we're not worried about the anticoagulant going in and affecting the liver. It's not in there. That's not an issue. We're not worried about the patient having a reaction to bovine thrombin. Now, the nice thing too about this process is it's more of a natural process. We're not adding in a bunch of stuff to the blood. So it allows for the platelet-rich fibrin to basically form a fibrin clot itself. And that fibrin clot is what's going to basically function as our barrier membrane to prevent epithelium from growing down into the surgical site and to help stimulate periodontal regeneration by releasing growth factors from the fibrin as well. Okay. So what studies have shown, we mentioned earlier with PRP, how they were kind of inconclusive if there was enough growth factors to really have an effect. This one has higher growth factors. So honestly, that's why this one's the second generation, because the first one paved the way for this guy here. Okay. So when you got your stuff done, you might have even had this guy done. Okay. Perfect. Yeah. Yeah. Beautiful. So it doesn't break the bank, but it does have a lot of promising studies that show it is effective. There's enough data out there to say, yes, this is a good procedure to have as an adjunct to surgical intervention. Okay. Yeah.
He explained it.
Yeah.
He was like, oh yeah, most people that were just extracted, it takes like a week or two to heal over to get pretty good.
Exactly. Yep. So prime example, that was probably those growth factors coming into play, it's stimulating the tissue heal. Yep. So let me show you what that looks like, and then we'll probably get more. So here is that platelet-rich fibrin. This little white thing right here is the fibrin. Okay, so it's actually not liquidy like the PRP is. It comes out almost like a gel type system. Kind of almost feels bad. You take fat on the stain. Kind of look like yeah, it really does. It looks like you guys are all little fibrin plots too. So basically, once they have that platelet-rich fibrin, they take it and they mold it onto the surgical site. So here you can see we have a periodontal flap. This right here, all of this is actually that fiber. So basically it's able to be placed on the area and molded to fit the cervical site. So any questions on PRP or PRF? Feel pretty confident? All right. Yeah. Let's take a 5-minute break. Let's come back at 3:30, okay?
Should we do it?
I think so.
You were still on board. How long were you talking for?
It was like 3 seconds.
She's just like, I'm like, you look so done.
I know.
I don't know. Most of the time we've been what's I'm looking at very bad. I'm sorry.
Most of the time, it's actually for me.
Yes.
Yep.
I did sleep more than usual on my exam today. But I still want
Oh, I gotta do all homework. I gotta do the careers presentation. I know, so I have to be-
I'll let-
Most of the time with those type of things.
Well, now. Well, now. According to the email.
What's your total?
Huh? Every three, I'm pretty sure it was broke. I wrote it 59. Everyone, yeah. Cause I read it.
I hate it.
It's just either.
Mhm. On Sunday now?
I mean, I wasn't gonna leave it till 9, but I like the option. Actually, no, I wouldn't. That would be setting Saturday, but still. It's not hard.
It's not hard, yeah.
It just takes time. I don't wanna go to bed.
Yeah, you're not.
Thursday and Friday.
Maybe I'll try to do, well, how much do next week? Or I guess this weekend. Let me see.
Well, there's 3 things due for her, right? Like the poster,
Mm.
the PowerPoint, and then the career PowerPoint, right?
Poster's done. PowerPoint's almost done. My PowerPoint's halfway there. No, it's. Ah! Last Christmas, I gave you my heart. But the very next day, you gave it away.
We talking to a person who's having 3 different conversations with them.
The screening would be like when we were doing like the decay, missing, and whatever.
Yeah.
There's,
You guys should have that paper, right?
yeah, we do. I personally don't have it with me.
Yeah.
So let me see. Season.
I thought it was like.
Oh, it hurts. Sorry, I'm just not expired. Gosh. Did we end up doing? Oh, shit.
I like my version from last night better than when I had to write off. So would be nice. I didn't finish my infographic. I feel like on the bus.
We have a clinic class next semester, like lecture.
I low-key think yes, but I'm not sure. I mean, I don't know what we'd be learning at that point. But
Yeah.
hopefully it's easy.
Okay, what if I change the document? I just like the insurance.
Paste.
Yeah.
TMT.
I got
Paste on.
I like, well, mine was that.
The K and Carrie are kind of using interchangeably. At least in those.
Yeah.
You're going down.
Okay, guys, let's get back into it. Okay, next one we're gonna talk about with biological enhancements is gonna be our goal and work with genetic coding. EMTs. We talked a little bit about EMTs, we were talking about, bone grafting. Bone grafts that have the ability for osteoinductive aspects are gonna be utilizing EMTs. So what these guys here are, they're regulatory Lego raisins, and what they've done is they've looked at the, possibility of periodontal regeneration through osteoinduction. Now, the downside of these is the studies have actually shown that when EMTs have been used for directly for periodontal regeneration, not within bone grafting, actually transplanting EMTs to the site, they actually found that the change resulted in two influences. Okay, not so ideal, right? We don't want that to become any worse. So because of that, they need more studies on this one. This one's not really currently being used clinically, but this could be one that you might see development in the future. Because if they can find a way to prevent the tooth ankylosing from happening, it'll be set. Okay, it'll be a really good opportunity for area regeneration. But still, the studies can show that it's not resulting in tooth ankylosing, but they're not doing it. Okay. All right. That's actually all I have for the biological enhancements. Okay. Next up, we're gonna talk about sutures. Okay. Now, with sutures, you're basically gonna get 3 different lectures of sutures. Okay. I've touched about it in my class. You're gonna hear more on sutures from Dr. Callahan and Miss Nettlespot. I believe she has Dr. Callahan from other lectures. So you hear from a dentist that actually places sutures, we'll hear about them. And then next semester, when you get done materials with Mr. Webb, you're gonna have an opportunity to actually practice placing sutures. Okay? Placing them even though we can't technically place sutures in real life, we can remove them. So if you know how to place them, you're gonna know how to remove them.
High school, we had to do.
No, you.
But I also don't have a lot of guns. It's really scary.
But just know, this isn't the first and last time you're gonna hear about sutures. We're looking at a couple of different sources, okay? All right, and the only reason it's been incorporated in my course is just because with perio, you guys do have the ability to remove these sutures. If you're working in a perio office where the surgeon relies on you to use the post-op, that post-op appointment involves suture removal. So it's very important for you to understand sutures and know the process of removal. I'm not gonna go into nitty-gritty details about the different types of sutures in terms of different materials or anything like that. You'll get that more from Callahan and okay. So basically with sutures, we want to make sure that we're using something that's biocompatible, non-toxic, flexible, and strong as well. We don't want it to break off, right? Now, when we're placing sutures, they make sure to place a lot of care and focus and emphasis on making sure it's not pulling on the tissue, right? So what they do when they place flaps and suture them is they try to place them passively. If we've heard that word thrown around in a couple of the videos that we watch. They're not gonna pull it down and hold it in place, pulling it down while they're suturing through and relying on the sutures to keep holding it there. It has to be passively laid over and be positioned in whichever direction it needs to be. But it can't be pulled, the sutures are folded on the tissue, it's just gonna rip right through, carry the healing process. And it really avoid placing any tension. All the sutures are doing is just holding that tissue in place, not pulling the tissue in place, just holding it in place. Now, with sutures, there's basically two broad categories that we can look at, multi-filament and monofilament. Now, multi-filament, I want you to think of a braid. Kind of like this picture here. They basically have a bunch of different strands that are kind of woven and tied together. An example of that is a black silk suture. I don't need you to know that. We'll get more of that for demo materials. We'll just kind of keep that in the back of your mind when you get into webs class. Oh, multi-filament, black silk. This we will talk about that. Now, multi-filament sutures, they're really great because they're strong and flexible because they have multiple strands to them. However, because there's multiple strands that look like this, you can see that there's a lot of different areas for bacteria to harbor, right? And so that can be one of the downfalls of multi-filament sutures, and we want you to know this, okay? Basically, these types of sutures have the ability to absorb and retain saliva, blood, any type of fluid in the oral cavity, and bacteria. Okay? Now that process, when it's absorbing the fluids and bacteria, is referred to as wicking, and that can actually trigger the inflammatory response. Makes sense, right? If we're harboring bacteria in that area, it's going to cause constant inflammation. Okay, so one of the main downsides of multi-filaments, it's not a complete restriction on using it. There's a lot of clinicians that use multi-filaments. They just have to be really cognizant of that possibility, kind of noticing it early on. Monofilament sutures, easy to remember. Mono, one, just one single strand. Okay. Now, the benefit of that is you don't have to worry about wicking with the monofilaments. They're not necessarily as strong as the multi-filaments, but they still are very, very effective. So again, the type of suture strictly depends on the clinician. Okay. And Dr. Callahan, when she comes out, she might even be able to give more information on why she chooses certain suture. Okay. Now, not only are sutures either multi or monofilament, but then they're also either absorbable or non-resorbable. Okay. Most clinicians that I've worked with, most surgeons that I've worked with, prefer non-resorbable sutures because they want to be able to control when the sutures are removed and the process, etc. Whereas absorbable sutures, they can absorb within a week. They can take 3 weeks. It just strictly depends on the patient. And a lot of the absorbable sutures they've found, they don't necessarily absorb as well as they'd like them to in saliva. Okay? But there's still excellent options. Again, it just depends on the clinician's preference at that point. Okay. All right, so types of sutures here. So there's basically 3 broad types, and Callahan, I believe, is going to teach you 1 or 2 of these, and then Webb will teach you another one. So we're looking at interrupted sutures, sling sutures, and continuous sling sutures. So let's break these down here. And the only reason it's important to really know what these are is, like I said, even though we're not the ones placing the sutures, we need to know what type of suture was used. So that way we know where the knots are. Because we have to know where the knots are when we're removing. Okay. So when we're looking at an interrupted dental suture, basically it's directly suturing the facial and lingual papilla together. Okay, so it's tied in each interdental site. So if you're reviewing chart notes and you're in charge of the post-op, you're reviewing chart notes and you're seeing an interrupted interdental suture was placed, you have to find the knots at each interdental site. Okay? You cannot forget sutures. These are incredibly important to make sure that they're removed. We'll talk about that more later. And in this picture, you can see how they're tied in each of those interdental sites. Right? It looks like this patient had a whole lot of work done. This was a full mouth rehab situation. And so you can see basically all the way across every single tooth, even different knots. Okay. So this one here is really good because if one of these sutures fails, it's still going to make sure that the flaps close. Right? Does this one fail, or everything else is still kind of helping, right? So it's a really good benefit of the interrupted, suture. Like I mentioned, there always has to be taken to know what type of suture was used and where did they place it, so that way you know how many knots you have to get on. Okay? So here's an example of what that interrupted suture looks like. Super straightforward. You're basically coming in from the buccal, getting your suture through the buccal tissue. You're gonna get your suture through the lingual tissue, move it around and tie it. Easy to see. Nothing really more complicated than that. Okay. So the suture does get cut, and then if they were to move it to the next area, they're gonna start that process all over again. So these individual sutures are individual. They are not connected to one another. Okay. And this image, these are all individually placed. This suture does not connect to that suture. Does that make sense? Okay. Just watch a quick little video here what this looks like in real time. Notice what I use more accessories as well. We're gonna grab that with their fingers. I have personal experience with it too. Well, it's not like it right down at the knot. And how do you do like 5 millimeters of height here? That's really, really, really important. If they cut it at the knot, if the suture's ever cut right at the knot, it's gonna come apart. So that gives it extra space basically to make sure that the knot doesn't fall off.
It's easier to remove when you're cutting it and you're getting it from the other side.
Exactly, yeah, so having those extra little strands also makes it easier for the removal, so you can have something to hold on to if you want. Okay. All right, so that's your interrupted interdental suture. Now let's get into your continuous sling suture. Now this one here is kind of a fan favorite. This one's used by a lot of different clinicians, right? Now this one's going to be placed for the interdental papilla, but then it's actually going to loop around the cervical portion of the tooth. So not only is it connecting the papilla, but it's kind of holding onto the tooth and pulling the tissue towards the cervical area. Okay. Now the thing with this suturing technique is the suture is not going to be tied at each individual site. Okay, this is basically only going to be tied at the beginning where you started the sutures and where you ended the sutures. So none of these are tied, but you're just going through tissue. It's tied right back here. Okay, you know your clinician or your surgeon utilizes continuous sling suture. You don't need to go in and cut each one of these little areas out. You just need to cut this out, and then everything will kind of fall apart. This is all connected. Okay. So when you're going through and you're cutting it, always make sure to just go to that most part of the surgical site. Cut your knot there, and then you're able to pull it out. Okay. So here's an example of what this guy looks like. So what they're doing is they're coming in from besides the facial here, coming in from the facial, and notice how they're not connecting the lingual patella to the facial, right? They're coming in and connecting that facial patella to the cervical area of the tooth, moving around, coming back, popping out the other interdental facial area, coming back through, no lingual contact yet, still just looping, still just looping. Once they're done with the surgical site, they come in and now they're coming into the lingual, And they're basically gonna replicate that same motion from the lingual side. Right, just moving it around the feet from the lingual patella, and at the very end is where they'll tie it. Okay? So again, if you see this on your patient, you don't need to go in and cut interdentally. You just have to clip this one knot, and everything else will kind of fall into this, right? Yeah, I'll show you a little video on this side here. There's a little video here to give you a different perspective. It's one place. Around that circle, the bottom and the old patella, there's the start to bubble and the bubble, and start to bubble the bubble. Wrap around, just tie everything in around the circle. Okay, just one area has that. Okay. Any questions on that one? Yes. All right, now we have the sling suture. So I'm just going to continue with the suture. The sling suture is very, very, very similar. Okay, but with this one, basically what you're just doing is like targeting one side only. So instead of starting on the buckle, going through that patella and then coming through the lingual patella, they're just going through your buckle or lingual patella. Right? So in this image here, you see we're coming through the buckle, coming and moving around the tooth, like over here, coming in through buckle patella on the opposite side, and then tying right here. So it does not penetrate to opposite patella, whether it's lingual or buckle. Okay. Let me show you a little video of that guy here. So notice how the flap is just really on the facial surface, okay? And we haven't flapped the tissue on the palatal. Because of that, they can use the sling suture, just moving it around. Tie on this side. All right. Here's another little video. If you guys want to look at that too, a little sling suture there. So any questions on the different things? Like I said, really broad overviews, how it's probably gonna come in and give you way more detail. So what I want to spend some time on with this is the actual guidelines for suture. Okay, so that's where we really come to play in this area. So like I mentioned earlier, when patients are post-op, depending on where you work, you might be directly involved with that post-op. Maybe that post-op scheduled in your column. Okay. Or maybe that post-op scheduled in the surgeon's column that they are busy or behind, and then they're like, yeah, I need you to go into my post-op order. This is especially prevalent if you work in a periodontal office. So if you work in a general dentistry practice, you might not ever have to manage suture removal. But if you work in a periodontist, you probably are going to, okay? So here's some broad guidelines here, and I'm gonna give you some little nitty-gritty details about this. We always have to make sure that we're removing sutures in a timely manner. So usually the rule of thumb is within a week of the surgical procedure, within a week of sutures in place, you're gonna remove them, okay? Sometimes they can go to 2 weeks depending on the surgeon, but most of the time they're not wanting to have those sutures in there past 2 weeks. Okay, it's too long, and then at that point, if the sutures are left in place for too long, it becomes an irritant, and the body will actually start rejecting it. It's gonna identify it as a foreign object. Okay, for the whole inflammatory, the chronic whole. So really important to remove in a timely manner and make sure that you remove them all, which kind of takes me into step 5 here. If you are removing all the sutures, if you didn't take note of how many knots there were, and you left maybe just 3-4 millimeters of suture material, it will cause the patient with relapse. Not a question about it. Okay, so it's really important to make sure that you got everything. So, removing them in a timely manner. Okay. Always make sure if you are going to be engaging in suture removal, read the surgical note. Okay. Surgeons are very detailed with what they use, what technique they use, what type of sutures they use, and where they place them. Even what type of thickness of suture they use. So you want to make sure that you read the surgical note prior to bringing the patient in, so you kind of have a mindset of where you're going, what was used, and how many knots are going to be doing. Okay. Make sure that you understand the sizing system. So I have a really good little table here to show you next. We're just going to skip forward to that here in a moment. Never allow the knot to be pulled through the tissue. Ever, ever, ever. One, that knot is super thick, so it's going to cause tissue damage and be uncomfortable for the patient. Most of the time, patients do not have to be numb for a suture removal. We don't. We go in there, click it out, and it doesn't even feel, really doesn't feel much like it. Okay. Who here has ever had sutures? Pretty straightforward, right? Even if it's not done, you get a suture on your arm and your face, it's usually not too big of an issue. But we don't want to pull that knot through the tissue, not only because we want to make sure that we protect the tissue, but also because that knot's been contaminated. That knot's just been hanging out in the oral cavity, it has saliva on it, it has bacteria, probably has food debris on it as well, biofilm, all that fun stuff. We don't want to take that knot now, force it through tissue, and then deposit all of that nasty junk that's been sitting on the suture for a week or two. Okay. All right. Let me go through this little sizing. So here's kind of the general size that we see with sutures. So we have 3-0, 4-0, and 5-0. Okay. Now these sizes directly relate to what the diameter is. So you'll see that the lower the suture size number, the thicker it is. So 3-0 sutures are 0.2 millimeters. Compared to a 5-0 suture is 0.1 millimeter. So really, really, really thin. So important to know, because obviously if we're doing a thinner suture removal, it's probably going to, your patient's probably not even going to feel that. Versus if we're removing a 3-0, you might need to warn the patient, they might feel just a little cool. It's not going to be painful, but it just might feel a little weird. Okay. So always make sure to take note of suturing size. I do want you to know this. Okay, I'm not going to ask you nitty-gritty details about specific diameter sizes, but I'm going to ask you which one's bigger and which one's smaller. Okay, and down here is a really good example of how we would remove those sutures. So here we have, what's the suture type? Interrupted interdental suture here. Okay, so basically what they're doing is they're going to grab this knot with forceps or hemostats. You're never, ever, ever going to use your hand near any of this stuff. Okay, so grab that knot with the forceps and pull up, and then you're going to flip one side of it, and you're going to pull outwards the whole thing. Okay, and cutting it like this is going to prevent any of that knot or bacteria or anything like that sinking back into the tissue. We're not letting that knot pull through the tissue. We're pulling it out of the tissue. Okay. Any questions on that? How are we feeling? We need another break before the period dressing? Alright. So, periodontal dressing, we've already talked a lot about this, I'm just gonna kind of go into more nitty-gritty details about it. And then, like I said, next semester with Mr. Webb, you're gonna have the ability to actually play around with periodontal dressings and practice placing it on your typodon. So that way, once you graduate, you learn it didactically, so you practice it as well, okay? Well, like I mentioned before, these periodontal dressings are basically just a protective material that we place over surgical wounds to keep it protected, to keep it locked in place and make sure that we can prevent food from getting in the area or patient damage in the site or anything like that. Okay. Now, periodontal dressings can also very commonly be referred to as periodontal pads. If you hear the term periopath, think periodontal dressing. Basically the same thing. Okay. Now, these guys here are going to basically facilitate healing. Because it's the site safe. They're gonna enhance patient comfort as well, because they're gonna isolate the area from anything external. And that comes in play a lot with gingivectomies. If we use one of these on gingivectomies, which most of the time we do, it's gonna really help prevent the patient from being uncomfortable. It's covering that connective tissue. Okay, so it definitely helps with patient comfort. It's also gonna help prevent post-op bleeding. Okay, post-op bleeding we'll talk about here shortly. It is kind of a common side effect to some extent. And this really helps prevent that from happening or worsening because it's holding whatever clot was forming underneath the perio dressing, it's gonna hold that clot in place. Whereas if the perio dressing wasn't there, probably within a day or two, maybe three, the patient's gonna pop that clot out. Then it's more uncomfortable and doesn't facilitate healing, okay? Also helps to maintain a debris-free area. Obviously, if we're covering the surgical site, it's not going to have as much ability to get food packed into the area. And these guys here, as I kind of mentioned over the course of the last few weeks, they may or may not be able to do it. It just depends on the surgical technique used. It depends on the patient and the clinician. Okay. That being said, I would say more than 9 times out of 10, almost 10 times out of 10. Gingivectomies are going to require the placement of periodontal dressing. The only instance I can think off the top of my head when we're not going to use this on a gingivectomy, I think I showed you a video last week where it was just tooth number 8 where they briefly did a little laser zap on the gingival margin. They're probably not going to place a perio dressing for that. But if it's like a true gingivectomy where they're going in with the intent of removing gingival hyperplasia, they're going to want to place a periodontal pad. Okay. And like in this picture, like I said, you'll show you learn it next semester, but basically all you do is you take this little material and press it and approximately into the and it basically essentially harness that area. So it's pretty straightforward and pretty fun. Now we have 2 main types of periodontal dressings. We have either chemical cured case or light cured case. Okay. So chemical cure is basically when we have 2 separate tubes that have 2 different materials in them. We just place them on a little slab and mix it together. Okay. Then we take that mixture and place it on the surgical site, and it eventually hardens in place, usually over the course of a couple of minutes. Okay. So some examples are Copac and Periocare. This one here, Copac, is what you'll actually be practicing with next semester with Mr. Webb and materials. Okay, that's the chemical cure. Then we have our light cured paste. So these guys here require polymerization. But after we place it, it's not going to solidify until we get it with the light. Okay. Now with these guys here, you always want to make sure that you're reviewing the manufacturer's directions and practice on the typodon before applying. These ones are a little bit more aggressive. Okay. Less room for error with these guys. But the good news is that these have come with the ability to be clear or transparent. So if patients are worried about aesthetics, if they have surgery done on their maxillary anterior teeth, they might not want something like this placed on their teeth. They might be self-conscious of that. And in those instances, our light cured paste can be a really good alternative because they are clear. Right? If you're up close enough, you're totally going to see it, but it might make compared to the chemical. And an example of this one here is Garrett. Okay. Now, I'm going to be honest with you. I personally have never used light cured paste. They're more expensive as well. And because there's more room for user error, most of the time, offices that I work in at least, always gone with the chemical cure. It's way more controlled and it's pretty darn easy. I mean, mixing it up takes less than 30 seconds. So It's not like it's this big ordeal or anything like that. So here's what the chemical case looks like, and this is what you'll do next semester. So you basically have two different materials. You'll learn all about what the nitty-gritty of the materials next semester with labs. Place equal amounts on the mixing pad. You're gonna come in and mix it together. Make sure everything is very, very, very well mixed. You don't have any different times than mixing it around. And then basically it starts forming a little ball of pipe. And what they do is they pick it up, kind of roll it into almost like a little cookie roll, and then place it on the surgical site, push interproximally, and kind of solidify it. Okay. And then here's just a picture of that Periodontal right through paste. So it's just one tube. So basically you just take this, put a little syringe tip on it, and directly apply it to the surgical site. Okay. Again, if you work in an office that utilizes pipe through paste, check with the manufacturer directions because they vary substantially between different products. And it's definitely not as user friendly compared to the other stuff. Okay. All right, so general guidelines for our management of dressings. So like I just mentioned, we're going to be basically, when we're placing them, make sure to push that material far enough and proximally. These are locking to the teeth mechanically. They're not embedding into the tooth enamel, they're not embedding into the cementum or the tissue or anything like that. This success of the periodontal dressing staying in place is reliant on mechanical compression and proximity. You want to make sure you put enough pressure to lock it into place. And always remember, less is best. Okay, only use enough material to cover the wound. Anything more than that has more chances of falling out. Please encourage coming out. Okay, falling out. Now, when we're placing this, we always want to make sure there's no occlusal contact between the material and the occlusal arch. So this should not come into the occlusal area at all. If it does, it's going to probably fail and come out the window. Okay. Now, with our period dressing, we're going to replace these every 5 to 7 days. So again, usually our first post-op appointment is at the 1-week mark. At that time, you're going to remove the dressing, determine how things have healed. And at that visit, you might need to place another dressing. Okay. Basically, until that wound is healed, you're going to be replacing it every 5 to 7 days. Okay. Now, when you are removing periodontal dressing, you want to be cognizant of sutures, because sometimes that suture material can kind of get locked in and embedded in the dressing material. So you don't want to rip out the material and then rip out a suture as well for the tissue, right? That would be very blunt. So most of the time when we're removing these, then you'll get experienced hands-on with this next semester. You can kind of rock it back and forth and try and visualize underneath it to see if the sutures are stuck to it. And if they are, you're going to cut them before you remove the period dressing. Okay. All right. So here's a little example of what this looks like here. So here we have our surgical site. You can see they made a little tootsie roll shape. And they're basically just raising it along that digital margin. They're not putting into the occlusal area of that tooth at all. They're just covering the surgical site. And then most of the time, they're going to loop it back around the opposite arch, so that way they can get that interproximal mechanical locking happening. Okay. And then here you can see with the occlusal, they're making sure that that dressing is not ever coming in contact on the occlusal surfaces when the patient occludes. Really, really, really important. Okay. So any questions on period dressings? Big thing I want you to take away, like I said, you'll learn all of this next semester, but big takeaway is we're going to place them every 5 to 7 days. And you want to make sure that there's no sutures attached to it. Okay. All right, don't stop. We are almost done. We need a break or do we want to just power through? Power through. Okay. All right. So post-op instructions. Now these are going to be instructions, kind of generally speaking, for all of the different surgical procedures that we've talked about. Okay. Now, of course, some procedures might have other verbiage you might need to include, like the crown lengthening procedure. We talked about how to increase sensitivity. So you're going to include that in your verbiage. But generally speaking, these post-op instructions work for every type of surgical intervention we have. So first and foremost, we're going to restrict self-care at that surgical site. Okay. Most of the time, we're going to be instructing patients not to brush that area until we see that for their first post-op visit. I know. So they brush the rest of their mouth, but we don't want them touching that surgical site. Sometimes the surgeon will depends on what was done. Sometimes the surgeon will give them a very, very soft bristled toothbrush that they can lightly brush and do occlusal surfaces. But they're gonna be instructed not to come near that toothbrush margin. And you do not want them disrupting any of that healing process. And a week worth of buildup of biofilm isn't gonna improve the healing process. It's not gonna do too much. Okay, so you want to restrict their self care. We're gonna prescribe chlorhexidine for these patients. Okay, reason being is that chlorhexidine is gonna help facilitate biofilm control. We know that it's a really good standard for minimizing uveitis and biofilm. So while they're restricted on their self-care, we're gonna have them rinse with chlorhexidine to help keep that area clean. Now with rinsing, they're gonna be instructed to do a very gentle rinse. They're not gonna be switching like a maniac on the okay. Usually I tell patients to even kind of just tilt their head to whatever side that surgery's on and just kind of let it soak. Maybe move it around a little bit with their tongue, but they're not going into the intent of trying to force it under their dress and force it anywhere their proximity or anything like that. Okay. Now, patients are going to be usually have a conversation about analgesics. Most surgeries aren't going to prescribe narcotics. We've tried really hard to pull back on they go through crisis, right? So they've tried really hard to pull back on how many narcotics are prescribed. But there are instances when they will prescribe narcotics. There are a lot of times they'll actually prescribe them a combination of ibuprofen and acetaminophen. So a lot of studies have shown that those medications combined can actually be just as effective as narcotics. Having to deal with opioids. So it can be a really good alternative. So usually, I think PRN, that usually the instructions for analgesics is, we're gonna have the patient take ibuprofen and acetaminophen in combination with each other for at least the first 48 hours. And even if they're not in pain, we want to try and make sure they don't start happening, right? And the thing with analgesics is once the pain is there, it's way more difficult to backtrack and make the pain go away. Versus if the medication's already in their system and then the pain starts coming, it's easier to manage. Okay. We're also going to have them on a soft food diet for 24 to 48 hours. Makes sense. Are we going to tell them to go home and eat some Cheetos on that side of their mouth?
Yum.
So soft food diet for the first 48 hours after surgery. And after that, they're going to be instructed not to be chewing on that side. Okay, so even when they can start chewing more hard and solid foods, we're going to have them chew on the opposite side of their mouth. Okay. We want to avoid the use of straws and spitting as well. A lot of these surgical sites are forming a blood clot. Okay, and any type of suction motion can basically pop that clot out, and that will interfere with healing. Not on par with surgical periodontal surgery, but here because I got heard of dry something. Right? That's what that is. Patient basically was forming a blood clot at their socket where the tooth was extracted, and they did something to pop that clot out, and now things are miserable and it's uncomfortable and painful because the wound's not healing. Same concept goes with periosurgery. Okay? So no straws. And I bring up avoid spitting with patients because what do we do after we're brushing our teeth?
Spit.
Spit, right? So I usually tell patients if you're cleaning your teeth, don't spit that water out, just kind of open your mouth and let it just drain out, rinse it again real quick and let it drain out. No spitting, okay? We're also going to have patients avoid physical exertion until our first post-op appointment as well. Okay, so these are kind of all post-op instructions until we see them for their first post-op. So hey, for this first week, until I see you again, this is what I want to do. No physical exertion, okay? That can increase the blood pressure, that can increase the heart rate, and that can also result in popping and clot. Okay? No physical exertion. Now, most of the time, I would say 100% of the time, patients are going to be small, especially when you've seen the videos that I've shown. It can be pretty barbaric. So smelling is normal. I'm sure your patients are aware of that, right? If the side of their cheek is full, that's totally normal and fine. So most of the time, surgeons are going to recommend placing ice packs on the area intermittently, usually 10 minutes on, 10 minutes off, for the first about 10, 12 hours of surgery. Some surgeons I've heard say to go 24 hours after surgery to symptoms, but don't say 8 to 10, okay? 8 to 10 hours following surgery. Absolutely no smoking during the healing phase. Okay, that's usually can be even a pretty big factor with whether or not surgeons are even willing to do surgery on patients that are smokers. They have to agree to engage in smoking cessation during this healing phase. We know how damaging smoke is to the periodontium, right? It's gonna be the same when we're trying to heal. We cannot have these patients smoking, okay? And at that point in time, to me, like, just stop altogether. You already stopped for a week, why not stop for another 2 weeks, and then 3 weeks? Okay? Let your patients know minor bleeding is expected and it's normal. Some patients will freak out if they go home that night and see a little blood release to that, spit their water out, or whatever they're doing. That's totally normal, okay? What's not normal is excessive bleeding. So if their mouth is still just gushing blood, they need to come back and help you guys immediately. But if it's just minor bleeding here and there, or taste the blood in their mouth, if they can't visually see it, that's totally normal. So again, we have to educate them on that ahead of time, because otherwise you're gonna be getting a phone call to your office frantically at 5 o'clock in the evening, freaking out about some blood, okay? And then always make sure to schedule that post-op appointment, usually within 5 to 7 days. So we're seeing the patient within a week of the surgery. And that's gonna allow us to assess biofilm, remove any biofilm buildup, assess the area dressing, all that. Okay? So any questions on your post-op instructions to your patients? Okay. All right, so let's talk about the steps involved in our typical post-op, okay? First thing first, patient interview. This is gonna be really important. You're not gonna just sit your patient down and have them open their mouth and start messing around with their dressing. Okay, you need to talk to them first. You need to figure out where they're at in their healing process. Are they in any discomfort? If they are, you need to get them a prescription. You need to do anything else in terms of this. If they prescribe antibiotics, talk to your patient and make sure they are still taking them. Okay. Antibiotics aren't prescribed for every surgical procedure, but they are prescribed for a lot of them. And if your patient says, well, most antibiotics are prescribed for anywhere from a week to 2 weeks, okay? And let's say you see your patient on day 5, and they have 2 more days left of their script. And they, well, I'm pretty much already healed, I don't need to take it now, right? Absolutely not. Anytime we're prescribing antibiotics, they need to finish the entire script. So talking to them about that, how many tablets you have of your antibiotic, reiterate it, be sure to finish it, okay? Do they need any more chlorhexidine? How are they doing on their ribs? If they need more, let's prescribe them more right there. Okay? Have they experienced any post-op bleeding? If so, how bad was it? Okay, that way you can relay that directly to the surgeon. And are they experiencing any thermal sensitivity? Is there any hot and cold? That's going to be really important to ask your patients that have received gingivitis or crown implant as well. Because if they are having cold sensitivity, how can we combat that? Sensodyne toothpaste, do we need to do a desensitizer? There's options essentially. Okay. As with every appointment, you're going to take the vital signs for sure, review medical history, all that fun stuff. Then after you get your patient interview, then you're going to actually start going into the nitty-gritty. Then you're going to lay them back and look at the period dressing. Most of the time, you're going to rinse that periodontal dressing with a warm salt water or warm saline even. Just to kind of clean it up, so you're gonna find there's some stuff hanging out around it, and then you're gonna remove the dressing. Okay, make sure you have the features underneath it if they are attached to the dressing as well. Okay, then once that's out of there, then you're gonna examine the surgical site. Okay, look for any tissue swelling or exudate. Because at a week post-op, if you see exudate forming, we got problems. Okay, we'll be alerting the surgeon to that. Okay. Then, after everything's exposed, we're gonna actually go through and remove the sutures, okay? You might have done that already when you removed the dressing. If you hadn't put them, it just depends. But if you had it, we're gonna make sure that we're removing the sutures here, making sure to keep care to not pull out, not through the tissue. Then, once everything is exposed, you assess the tissue, not probing it or anything, visually assessing it. Then you're gonna go through and help them with their biofilm, because there's for sure gonna be biofilm formation underneath that dressing. Okay, even if they didn't use a periodontal dressing, they're gonna have biofilm around that surgical site. So go through and remove it gently. You're not gonna be removing it with a polisher, right? That's too aggressive. You're just gonna do some scaling. Okay, and then remove that stuff out of there. Then if needed, we're gonna replace that periodontal dressing. Okay, remember this dressing is gonna be discontinued basically, once the surgeon says, okay, you can go back to just your regular self-care regimen. Okay, you can go back to brushing, flossing, water taking, whatever it is. Until that conversation's had, we're gonna be replacing that perio dressing. That means we don't have to do it. Okay, how often are we replacing the perio dressing? That's gonna be an excellent job. We're gonna reiterate self-care instructions, because things usually change after that first visit. Now, ultimately, we want to have them re-engage in mechanical plaque control and the brushing of the area as soon as possible. Okay, so sometimes at that first visit, it's like, hey, these have actually healed really nicely. You can go back to brushing. Other times, not so much. Okay, so if we are not wanting them to go back to their regular routine, we're just gonna change our self-care instructions a little bit. And most of the time, it's when we really incorporate post-surgical toothbrushes. There are toothbrushes that are specifically designed for surgical sites, so they're very, very, very gentle on the tissue. And usually we can talk to patients about using those as well, and just reiterating any other self-care instructions. Okay. And then lastly, we're gonna re-appoint them back. So usually the second post-op appointment is gonna be 2 to 3 weeks following the surgery. So it's usually about 2 weeks after that first post-op appointment. Week 1 post-op appointment, and another 2 weeks later, week 1. Okay. Questions on that? All right, follow-up visits. So until patients can perform their own self-care back to normal, we should be going in and basically removing and polishing as needed every 2 weeks. Okay. Usually, like I said, we're not going to polish that first post-op visit because everything's still too fresh and feeling and really irritate the tissue. But after that, every 2 weeks, if the patient has not been able to resume their home care, we need to help them. Okay. After the healing is complete, when a patient undergoes periodontal surgery, they are a perio patient at that point, which makes sense, right? So they're going to be on a periodontal maintenance regimen. There are some procedures like gingivectomies, obviously they're not true perio patients. But when we're talking about actual plaque procedures going in with the intent of regeneration, they are on a perio patient. Okay, so we're going to see them every 3 months as a 49 tech. Okay. Now, remodeling of the soft tissue can continue for 6 months after surgery as well. So make sure to let your patients know that too. You know, sometimes patients are really concerned about the aesthetics right out of the gate. They have to give their tissue time to heal. It changes a lot within those first 6 months. Okay. Questions on that? Okay. All right. So how soon after surgery should sutures be removed? 1 week. 1 week usually, yeah, no longer than 2 weeks. So 1 to 2 weeks. Okay. All right, guys. So that is all that I have for the lecture. And then for review, we will go ahead and do a little bit of. So next week we have our exam. It's going to be 50 questions in length per usual.
I can't. I'm just gonna like have. I'll just record this Kahoot, but just gonna watch me lose. Like 20 something place. Oh no.
Oh, and on the topic of study guide, there was one error on my study that I updated this morning. So if you downloaded the study guide for this morning, read down the morning. There's one section on there that was defects from chapter 3, which we talked about last semester. I have no idea why. Okay, I got it this morning though. So just make sure to re-update your study guide for today. Okay.
I think it was when you had like COVID or something, and we were playing Kahoot, I remember like she, you know, how she does it for like extra credit or whatever. Remember, I was like actually kind of trying. And then at the end, like we ended up losing. And I was like, ah, I'm like, that sucks. And it was like, oh my god, we were so close. We're like in the 28th. So I constantly think about that. Like, oh, we were so close. You almost got that extra credit. Oh, look at your cute little thing. Looks like Rango.
I just hear you're changing
You don't like the Rango? Dun, 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 dun. Dun, 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 dun. You don't like Rango? I love Rango. Mostly because my stepdad made us watch it every single day. Because I was like his favorite. And he always swore they'd make a sequel, but we all knew they wouldn't.
That's not the.
I think I'm just gonna take pictures of my x-rays. I took x-rays last week and I didn't grade them. Take pictures of my x-rays. I'm gonna go talk to my son. I'm gonna go home and I'm gonna go to sleep. I'm tired. Either that or go into the bathtub and then try not to die while I'm trying to sleep. Like, with the cats just watching me on the toilet. Hopefully I don't fall again. Well, at least we'll have like
Which type of access primarily involves the gingival margin and or equal periodontal with no Dental access is very superficial. Your periodontal access is basically involving dental margin, dental patella, and all of the infrastructure for the periodontal. Which of the following is not incorporated in the first appointment to treat necrotizing gingivitis? Very first appointment, which of these are we not going to do? The patient is gonna be way too sensitive and you try and remove biofilm substance in that first appointment, okay? We absolutely want to remove that pseudomembrane though, so that's gonna help try and start initiating the healing process. We're very gentle with removing it, but we do want to remove it at the first appointment. That's kind of our primary focus between that and the supergingival instrumentation. Okay? When treating necrotizing gingivitis, when should the second appointment be scheduled for?
Yeah.
I'm not sure.
I know it's one of the two. My the two or three. That's all. I remember it was an update. So I was like, oh, it's like 10 minutes. Goodness.
Okay, so with our second appointment, it's 2 days after that first appointment. And one way you can remember that, one way you can remember that is second and second, so 2 and 2.
I
Okay.
see.
Third, 5 days after the initial visit, 3 days after the second visit, right? Make sense?
So there's yeah, so the first one, and then 2 days later you come to that one, and then 3 days later you come to the third one. So I guess that makes sense.
Primary herpetic gingival self-resolved within 1 week, 2 weeks, 3 weeks, or is it not self-resolved?
I don't remember. I want to say 2 weeks. But oh my god.
Okay, it does have the ability to self-resolve. The only way we actually are able to treat gingival stomatitis, we can't even treat it, it's just more palliative care. And so basically trying to make the patient comfortable, so we prescribe medications and malfeasance during it, but those medications don't actually stop this disease process from happening. Okay, it's almost like the flu. Once you have the flu, you have to let it run its course. Same concept with this. Okay. Who's Laura?
Lauren.
Which
always wanted
is
that
the most
behind.
contagious stage of intestinal infection?
That's it. I'm just gonna be fair.
All of the cases are the absolute most contagious. Okay, each of the following are relative contraindications for periosurgery except one. Which of the following is not a relative contraindication?
That's a good question. I'm not kidney analysis or real estate. That would probably make the most sense. But I'm sure. Just kidding. It was diabetes.
Okay? Controlled diabetes is not a contraindication for surgery, right? Patients that are controlled have really similar feeling responses to very similar outcomes. Okay, the uncontrolled diabetes, they are non-compliant with self-care is definitely a contraindication because they're not taking care of their stuff at home. If we regenerate their tissue, it's just gonna go south again, if they're not flossing, right? Unrealistic expectations for surgery. What if we're doing a free gingival graft and the patient has an expectation for it to be perfectly beautiful? Right? Kidney dialysis is definitely a relative contraindication as well, because anytime the patients are on kidney dialysis, they don't want to be introducing more drugs into their system for their body to try to process. Okay? What type of wound healing involves the formation of a long-term closure wound?
Right?
Study this. Okay, so healing repairs, they usually say tissue heals, but it's not gonna go back to its normal position. That's what it's called junctional epithelium. It's healed, but it's healed in a different way than it was.
Repair.
Okay, it's not restoring energy. Long as epithelium repair. Think of repair as a scar as well, right? The tissue's healed, but it leaves a mark. It's not going back to how it was. That's your repair. Okay. Reattachment is whenever we go in and do a surgical procedure on a site that doesn't have periodontal disease. So for example, patient was aesthetic crown lengthening surgery. They don't want their gummy smile. We're gonna flap that tissue back, dissect everything away, and then place the tissue back over, and it's just gonna reattach. There was no diseased tissue. There's nothing new that needs to form. You're basically slapping it back in place. Okay. New attachment forms whenever we have disease present, and we're removing that diseased tissue and stimulating new attachment to form. Okay, so new connective tissue is going to form. And then regeneration is full-blown regeneration where we're going to use cementum, new PDL, and new alveolar belt. Okay. Questions on that? All right, what degree of wound closure requires granulation tissue to form to facilitate fluid? What's our primary intention? Wounds come close together. Secondary means granulation tissue to form. Tertiary, what's tertiary? Dog side wound, we're leaving it open to let it breathe, and then we're gonna close it up later, okay? What's coronary intention? It's the thing, okay?
Who would pick that one?
Which type of incision enters the tissue about 1 millimeter away from the margin and follows the scalloping of the gingiva?
I do remember this. I'm assuming. Yeah, I always think it's that one, but I also haven't been paying attention to much. What I say.
The one that's basically used for gingivectomies when we're doing a scalpel gingivectomy. Okay, basically they're positioning the angle of the blade 45 degrees in relation to the cube and slicing from corona or slicing from apical position.
I know
to
about
corona.
incision.
Okay, for the big curve is inside the soul. Okay, so that's the one where they're inserting it into the cellular tissue and basically incising away from the your internal bevel incision is this guy here. This is the one where they basically follow the contour of the gingival margin. Okay. All right. Scallop does not exist. It's not a real incision. At all.
I'm literally, I have the mind of a master today.
Is expected to result in healing by
I usually don't do that, but on the exams. Okay.
picture of the study was that
And we repair.
modified equipment, after a modified equipment is done or flat for access, they have the formation of a long junctional epithelium. Okay? Right. Right, what is the ultimate goal of osseous resective surgery? The ultimate goal, okay?
Miss McCullough, do you think I remember? I do remember us learning about this, and I do remember taking a quiz about it. But still, it was blue.
Surgery directly going in with the goal of 6 millimeter pocket and turning it into. And the way we do that is by supplementing tissue in the bone. Okay. Improved aesthetics, we really actually don't see improved aesthetics with osteoresection. Most of the time it actually tends to kind of have healing. Okay. It can stop the inflammatory process in theory because we're eliminating the periodontal pocket, so that's not like a direct relation to us going in and performing osseous resective surgery. And osseous resective surgery in and of itself is not going to be a regenerative procedure. It's a resective procedure. It's going to take away tissue. It's not going to intend to regenerate anything. Okay. Which of the following is correct regarding the placement of the flap after osseous resective? Flap that tissue back, remove the bone. What are we doing with it?
You put the flap upwards, you cut it from the bottom, and then you go up on the crown. It's technically the same thing like that, right? Is that what that means? Because on the coronal, it'd be like going.
Our flap is always going to be placed, or most commonly placed basically after osseous resective surgery. Just think again, we're going to the intent of reducing the pocket. So if you pull that flap down, it's going to reduce the pocket. Right? We're going to have more teeth that's exposed unfortunately, but the pockets are going to be one more. Okay. There you go. Someone's like bringing something process. Which term best describes the graft material that acts as a scaffold for the host osteoblasts to migrate, attach, and grow on? What's in the scaffold? That looks like a ladder.
Yeah. On like induction, conduction, all of it. It starts with osteo and induction. It was conduction.
Induction is when we're basically having just the scaffolding material. Basically, just have a bunch of little square boxes that are placed in the tissue. And those boxes help stimulate our body to fill them up with osteoblastic activity. Okay. Osteoinduction is when we have EMPs, or bone morphogenetic proteins, inside the material, so inside in induction, that are stimulating growth. They're recruiting more osteoblasts to that area. Okay. And osteogenesis is when we actually have osteoblasts within the graft material that contribute to regeneration. Okay. What type of bone grafting material is taken from another?
Oh, class. One of the few things I do.
I don't even know.
It was. Oh. But once it's class, I'm like. And then auto, like your.
Autocrat, auto, like an auto operation that's coming from myself.
And then I believe Zeno, kind of like cats.
Plastic, artificial material. And xenografts are from another species.
Thing or two. If the question is only that one, then I can answer stuff.
What is the primary purpose of a barrier membrane during PCR?
I'm going to do the shower.
This is the reactions from my.
It was red.
Okay, so we know that epithelium grows really quickly, so we're trying to regenerate connective tissue, alveolar bone, epithelial fibers. We have to keep the epithelium out. Whole purpose of the barrier membrane, okay? Technically, it does hold the graft material in place, but that's not the primary purpose of using it. We're using it with the intent of keeping the epithelium out. It does. No, it actually doesn't really protect the wound from external stimuli because that barrier membrane is going to be super over time. Okay. And impede undifferentiated cells from the PDL in the grafting area. We actually want that to happen. That's where we get our regeneration. Those stem cells basically from the PDL come in and differentiate into osteoblasts or cementoblasts or fibroblasts to stimulate the regeneration of our tissues. So barrier membrane is strictly going in with the intent of keeping that epithelial tissue out of there. We don't want it in there. Okay. Okay, which surgical therapy may result in a higher passion here.
I remember like the slide, and I remember what it looked like, and it was ugly. And they were like, that one isn't gonna give you the aesthetics. Just kidding, it's for gingival. There's one that ended with graft.
Results in better aesthetics, so we tend to not get that higher passion here. That's strictly associated with the pre-gingival graft, okay? Poor vascularity to a gingival graft site will most likely result in.
Looks good. Tissue necrosis.
Accumulation of vascularity. Okay, so because the tissue becomes
That makes more
necrotic,
sense.
then we see a delay in wound healing, right? Then we might see poor aesthetics, then we might see increased discomfort, but it's all stemming from the tissue necrosis that occurred from the poor vascularity. Okay, does that make sense?
Oh, yeah. That's the.
What is the anticipated degree of wound closure at the donor site for a pre-gingival graft? Site of a pre-gingival graft.
Well, not this one. This is stitches. It's not third.
Where
Let's stick with that.
There's some. Remember, regional graft, basically cut a little square rectangle and take out all of that tissue. Because it's such a big stand, and suture cavity.
Her.
Other than that, the donor site for regional graft is going to be secondary intention, with granulation tissue to move it. Okay, if this second degree of wound closure at a subepithelial tissue graft, that would be your primary intention. We're able to see your power. Regional graft, that's also okay. And tertiary intention, just a little tip, don't ever select anything with tertiary intention with them.
Got it.
You don't let any tertiary stuff.
I don't know how I ended up there, but.
I got it.
Love that, how we have movies.
This procedure may be recommended for patients with subgingival decay that requires restoration. That's just subgingival decay.
You sound like the Beetle. I was in my closet. Oh, is it functional crown link?
When it's going for crown length, I mean, that's for a functional standpoint, decay has extended so far subjectively that if we were to place a restoration there, she's gonna impede on the biologic twist, right? We need enough space between the restoration of folks. So basically, we're going in to remove the bone and then pull the tissue down. Okay. Gingivectomy really doesn't have any tie to subgingival decay with restoration, that's just strictly tied to the gingival margin of the growth. And apically repositioned flap is not going to be enough when the decay extends too far subgingivally. Even if we reposition the tissue apically, we're still worried about infringing on biologic width of the bone. And that's why we have to go in for crown lengthening and remove bone and tissue and flap. Okay. How quickly does the gingiva grow over a connective tissue?
I'm gonna. I'll go with 25.
What you win for today?
I have no recollection. What was it? 0.5.
Millimeters a day. The reason we need to know that is because when we're talking to patients, if we know there's a 5 millimeter wound, you can kind of anticipate how long that wound is going to take to heal, knowing how quickly the tissue grows. Okay?
I see.
25 millimeters a day. Should you know that?
5 millimeters a day.
PRP commonly comes from an allogenic source.
Oh, is this a true or false?
Thrombin, calcium. Today.
What's I got?
So this one, because it has to be graph because that's the blood, right?
Yeah. That's what's baby.
Where does PRP come from?
Blood.
Autogenous source, coming from our cells, okay? Allogenic, allo is someone else. PRP, that platelet-rich plasma, is coagulin, thrombin, and calcium. That's how we get that issue with Easter error, okay?
First one.
PRS, platelet-rich fibrin, also comes from an autogenic source, but it is not going to be mixed with these things, okay? There's a big difference between those two.
Who's year be year? Leave him alone. What's the
Summer, not as much as the healing process.
I'm not really sure.
Or is that charger?
Yeah, those little teeth marks are me. No, look. Look, what was that? Two-stage approach?
Today, requiring 2 appointments. You start again, covering the tooth up. And back up.
They chose if this is there. Thanks, Betty. Hey, both. They really like this thingy. I think they like, look, because it used to be all long.
Implant should be probed 6 weeks after placement to determine the level of osseointegration.
Even I like I need to ask my parent. Well, I got my mom for Christmas gift. I need to ask everyone, like, what do you want now? Because I'm not gonna spend money in December. You know how much money you spend in December? Like, I have one gift done, and I want to get them all done within this month because I'm not. Get it. Phoenix and all the stores. Five Below, Manito, Dito. Maybe like regular mall. They sell a Hello Kitty now. Sorry. I'll go with Delila. She's smart. I was walking because I was getting my service at the store. So I was like, I'm gonna walk further because I need to get an Uber. Literally as I'm walking. And then watch it fly away. I was like, It's the last one.
At risk for waking. Material that retains bacteria can trigger the inflammatories.
That is a good one. So I'm not gonna get this way anymore.
Thank you.
So I'm not gonna get the cat. Okay. Did I win? Okay, I just need to take this off.
I forget that. Yeah, you want this? What is that? It's pumpkin bread. I didn't bite it or anything. I didn't bite it. I just like took parts of it. I know.
Austin just wants to talk about that. Because she extended it for us.